Ladies and gentlemen, I'd like to thank the organisers for inviting me to speak on this very important topic that affects a high proportion of glaucoma patients across the world. The EAGLE study was a randomised clinical trial designed to assess the relative benefits of clear lens extraction versus peripheral iridotomy. A number of financial disclosures, though none of them really relate to this topic. So what is the evidence for lens extraction as a primary treatment for narrow angles? For primary angle closure glaucoma? What is the role of iridotomy in relation to lens extraction? Well, in the EAGLE study, which was published in The Lancet in 2016, the study investigators theorized that as primary angle closure glaucoma is a leading cause of irreversible blindness, in early stage disease, intraocular pressure is raised without visual loss, and because the crystalline lens has a major mechanistic role, lens extraction might be a useful initial treatment. Between 2009 and 2011, they enrolled patients from 30 hospital eye services in 5 countries. Randomized and a web-based application, patients were assigned to undergo clear lens extraction or standard care with peripheral laser iridotomy and topical medical treatment. Eligible patients were aged 50 years or older, did not have cataracts, and had newly diagnosed primary angle closure with intraocular pressure of 30 millimeters mercury or more, or primary angle closure glaucoma. Now, as is common in many UK funding authority sponsored trials, the primary endpoints were patient-reported health status, in other words, quality of life, but also intraocular pressure was an endpoint in this study. And the incremental cost-effectiveness ratio per quality adjusted life year gained at 36 months after treatment. This was an intention to treat analysis. As I mentioned, the study was performed at 30 centres in 5 countries. 22 of those were the United Kingdom, 2 in Singapore, 2 in Malaysia, 2 in Hong Kong, and 1 in Australia. The investigators recruited patients who were phakic, aged 50 years or older, in order to limit the effect of loss of accommodation associated with clear lens extraction, and had either newly diagnosed primary angle closure with an intraocular pressure of 30 millimeters of mercury or more, or primary angle closure glaucoma. Now, primary angle closure was defined as iridotrabecular contact, either oppositional or synechial, through at least 180 degrees of angle on gonioscopy. Primary angle closure glaucoma was defined as the same, plus either reproducible visual field defect or glaucomatous optic neuropathy, or both, with a pressure of 21 or greater than 21. 805 patients were assessed, 419 randomized, 204 randomized to clear lens extraction, 205 to iridotomy. And I would reiterate that the mean starting pressure in each group was 30 millimeters of mercury. 2/3 were primary angle closure glaucoma. Only 1/3 had primary angle closure without glaucoma, which is probably not surprising. To assess the primary outcomes, they used a repeated measures mixed effects model to analyse the EQ5D scores and the intraocular pressure based on follow-up data at 6 months, a year, 2 years, and 3 years. And as I think has been well publicised, at 36 months, the quality of life EQ5D scores and the IOP levels clearly favoured the clear lens extraction group over the iridotomy group. And you can see that in both these analyses, there was a significant difference at 3 years between the two groups. In this forest plot with quality of life to the left and IOP to the right, the bars that move towards the middle favor clear lens extraction, and the bars that move towards the periphery favor standard treatment or PI. So in other words, if quality of life moves to the right, it favors clear lens extraction, whereas if IOP moves to the left, that's favoring clear lens extraction. And you can see that the bars for primary angle closure glaucoma, PACG, clearly favor clear lens extraction in both quality of life and IOP. And the primary angle closure without glaucoma does slightly favor clear lens extraction, but to a much less degree, and in fact almost favors standard of care for quality of life. If we look at other quality of life measures such as the NEI VFQ-25, that significantly favored clear lens extraction. If we look at the more glaucoma specific quality of glaucoma utility index quality of life measure, that favored clear lens extraction. And even if we look at medication in terms of eye drops, that also favored clear lens extraction. However, there was no difference in terms of additional glaucoma surgery, angle closure at 36 months, syncytial closure at 36 months, or visual fields. Does this mean we should do clear lens extraction instead of PIs in everyone with angle closure? Well, obviously not. The IOP benefits of clear lens extraction are greater with higher starting pressure, and in Eagle, the mean starting pressure was 30 millimeters mercury. The quality of life benefits of clear lens extraction will be greater in high hypermetropes. In Eagle, the mean refractive error was 1.6 for clear lens extraction and 1.1 for laser iridotomy, so they were not particularly high hypermetropes. So the entire quality of life benefit could not be attributed to the removal of hypermetropia alone. These results do favour clear lens extraction much more strongly for primary angle closure glaucoma than primary angle closure. Not surprisingly, in a patient with glaucoma, you're going to treat them more aggressively, and this helps justify that. These results may not be applicable to those with severe glaucoma or low starting pressures. For instance, the low starting pressures, the IOP lowering may not be so significant. And those with severe glaucoma, there's always the concern that simply removing the lens may not be enough to prevent glaucoma damage in those who need very low target pressures. The pressure was 1 millimeter mercury better in the clear lens extraction group, which doesn't sound like very much and perhaps not undertaking invasive surgery for, but only 21% required glaucoma medication compared with 61% in the PI group. So clearly, anatomically correcting the angle closure by removing the lens is much more effective in lowering the medication burden than simply opening the angle with PI. And the vision was slightly better overall by 3 ETDRS letters in the clear lens extraction group. So in conclusion, the Eagle study does not apply to patients with narrow angles alone who don't have angle closure. The Eagle study may not apply to patients with severe glaucoma for the reasons that I mentioned, that there may be a concern that it might not get the very low target pressures that are required with lens extraction alone. The Eagle study may not apply to patients with low starting pressures. And the Eagle study may not apply to patients younger than 50 years old who still have accommodation, and then that may negate some of the quality of life benefits of lens extraction. The Eagle study does suggest both IOP and quality of life benefits from clear lens extraction if the angles are closed and the pressure is high. Thank you very much for your attention, and thank you very much for the kind invitation. I do hope to be back at the ESCRS in person next year.